Can everyone hear me okay? Great. So for those of you who don't know me, my name's Madeline and I'm one of the editors from Therapeutic Guidelines who worked on this latest update to the antibiotic guidelines. I have the pleasure of chairing this first session for the symposium, and I'll just let you know that all the speakers that will be presenting today were on the expert groups that updated and reviewed and updated the antibiotic guidelines. We're in very safe hands. So to kick off, our first two speakers will be presenting on the updates to the sepsis content in the antibiotic guidelines. And so I'll start with Ed Raby. Ed is a clinical microbiologist and infectious diseases physician based at Fiona Stanley Hospital in Western Australia. His main clinical interest is skin and soft tissue infection in the setting of burns and diabetes-related foot disease. So Ed, if you'd like to come to the stage, thank you.
Probably need to bring this up. Can you all hear me at the back? Yeah, great. So I've put sepsis recommendations. I should probably put a caveat here that this is adult sepsis recommendations, and Brendan's going to step up and speak about the paediatric aspects of this. I also want to say that these 3 points that have been highlighted for discussion, they're here because they are contentious. There isn't absolutely clear evidence to drive any of these, and so that there was a lot of discussion and debate. So what I'll try and do is highlight some of the main points that we considered as we were coming up with these recommendations. And the three things I'm going to talk about: the timing of antimicrobial administration in suspected sepsis, community-acquired sepsis of unknown source, some considerations around the choice of antibiotics for that, and then the dosing frequency of fluclox and cefazolin in sepsis. So first up, this kind of summarises the TG approach to the timing of antibiotics for sepsis. So there is two components to this to think about. So the first is the columns going down. So on the left, patient is immunocompromised or otherwise vulnerable to sepsis, and I'll come back to explain that in a bit more detail. And on the right, patient is immunocompetent and not vulnerable to sepsis. And then as you come down, either the patient has septic shock, in which case in both groups, then antibiotics should be administered within 1 hour, ideally from the time of recognition of septic shock. And then the second row, patient has signs of organ dysfunction but not septic shock. So these are people with sepsis, suspected sepsis, but don't have the features of septic shock. So in patients who are immunocompromised or vulnerable, the recommendation is to administer within 1 hour. Whereas on the right, there is an opportunity for people to step back and think and reassess and get all of the investigations done in a rapid and timely way before making a decision as to whether this patient really does most likely have sepsis and be administered antimicrobials, or there are much more plausible alternatives, and so go down a sort of a non-infectious, non-infected pathway. And I guess this is recognising that part of what we're trying to do is optimise use of antibiotics and avoid unnecessary starting of antibiotics, which often leads to ongoing administration of antibiotics over several days as people kind of have the reassessment to get rid of them, but also we don't miss other important critical diagnoses within that early assessment phase. And this recommendation is really based on two big documents, so the Surviving Sepsis Guidelines and then the Clinical Care Standard, which largely mirror each other. But one of the, I guess, discussions and points that we picked up on was in the Surviving Sepsis Guideline, they talk about high likelihood, and that's mirrored in the Clinical Care Standard. There's this concept of high likelihood that organ dysfunction is due to infection. And the discussion around the table is that this is actually quite a challenging decision to make, especially for junior doctors in the emergency department or in rural areas. Trying to decide, does someone have high likelihood or not? It's kind of grey. So the decision was made to emphasise more people who are at risk, so people who are immunocompromised or otherwise vulnerable to sepsis, recognising this group are the ones who are most likely to have poor outcomes if sepsis was missed. And so this table linked here to MB1 gives you the list of people who are most vulnerable to sepsis and therefore at increased risk of poor outcomes if sepsis is missed. And this includes both young and older people, Aboriginal and Torres Strait Islander people, people with impaired immune systems, and this list is the list that you'd be familiar with that's being used elsewhere in the guidelines. People who've recently had, and that's within the last 6 weeks, invasive procedures or surgery, people who've got established breaks in the skin integrity, so burns or obvious skin infections, people who inject jugs, people who have indwelling lines, and people who are pregnant or who have been pregnant in the last 6 weeks. So these are the groups that we're trying to focus on to get antibiotics in early. I don't know, should I just go through these and then we can come back to questions at the end? Yeah, great. So the next one I wanted to highlight was community-acquired sepsis of unknown source. So this is in itself a really tricky concept. It's really poorly described in the literature. We don't really know when people who present first up and have this diagnosis of community-acquired sepsis of unknown source, we don't really know where they end up in terms of what diagnosis they end up with or what microbiology they end up with, to be able to have a better idea of, when you've got this person who's unknown, where to lead. The most common diagnoses from observational studies seem to be urinary tract infection, pneumonia, and primary bacteremia, which I suspect will come as no surprise that those three are the main three diagnoses. And then the most common pathogens, it's really a mixed bag of gram-positives and gram-negatives. Looking at that diagnosis list, it's not surprising we're seeing E. coli, beta hemolytic strep fairly high on the list, so people initially without the evident cellulitis that will come up in the next day or so, Staph aureus bacteremia with primary bacteremia or an occult source, strep pneumo, Klebsiella pneumonia bacteremia usually associated with urinary tract infection. What's interesting to me is that abdominal infections generally don't end up on this list. So people with gastrointestinal tract infections are usually pretty well picked up and don't fall into this unknown source bucket. But it's more of a mix of UTIs and pneumonia. And so we're really focusing on those pathogens and those diagnoses. So it's maybe getting a bit small for the people at the back. But within that, thinking about those kinds of groups, we continue to recommend aminoglycoside-based regimens for the majority of patients. And this is recognising that low rates of aminoglycoside resistance in community-acquired gram-negatives, so there's E. colis and Klebsiellas, and that the balance of benefits and harms favours the use in life-threatening infection. We know that they will generally be effective and generally be safe. There is the option for the Meropenem-based empirical regimes, and these are recommended for people who are at higher risk of melioidosis or those with multi-drug resistant gram-negative bacteria. PIP-TAZ is not recommended as a first-line therapy for sepsis of unknown source. We feel the balance of benefits and harms does not favour its use. And resistant gram-negatives to PIP-TAZ, the rates are higher than those for the aminoglycosides. And this is partly based on a lot of discussion about aminoglycosides, which have been recently reassessed by UCAST and CLSI in terms of their guidance and also the breakpoints that they're offering. They undertook large reviews of both the clinical data, which is very sparse, and PK/PD data. So in fact, a lot of the UCAST and CLSI recommendations are based very heavily on PK/PD data, which led to the revision of their breakpoints, which has made it a bit tricky in terms of some of our reporting is going to be discordant with what's recommended. But really, we're talking about the first day or two where we're not going to have bacteria known, and so it's empirical antibiotics to then be to be driven by cultures in the next day or so. Interestingly, around the same period, the IDSA guidance continues to recommend aminoglycosides, particularly for pyelonephritis and complicated UTIs. So that's one of our main targets in this unknown source group. And the Scottish group gave out a piece of advice that they also continue to use aminoglycosides for abdominal infection, urine and sepsis based on their extensive experience, stewardship principles and surveillance, which continues to show low rates of aminoglycoside resistance. They haven't clinically observed loss of effectiveness, and there's been no change in susceptibility patterns. And that's also true for other regions where susceptibility has been looked at. And this is from the latest AURA report, comparing cephalosporin, so ceftriaxone resistance rates on the left and gentamicin or tobramycin on the right for E. coli, noting that E. coli is the pathogen on that list which has the highest rates of aminoglycoside resistance. And across most of Australia, aminoglycoside resistance in E. coli is much less than 10%. I appreciate there are going to be discrete areas, particularly of the country, where this is not going to be ideal, and so there is the possibility that certain hospitals or areas would recommend amikacin rather than gentamicin in that context. And it's also, when you're looking at these, you're thinking 8-9%. If we're going to have 8-9% of our patients who are resistant to this, but it's not, this is just the E. coli. Klebsiella is much less, and of course a lot of our unknown source patients don't have a gram-negative at all. They've got streps and staph and other things. So when to use a meropenem-based regime, I think this would be fairly self-explanatory, most people in this room. When multi-drug resistant gram-negative is likely, and this is the bit I'd like to highlight, and then the traditional recommendations for those around increased risk of melioidosis. So this will be too small for people to read, but I want to flag this as a box for people to look at. So this is the list that's been developed for risk of multi-drug resistant pathogens. And I think they're all things that you and I would think of, but it's a checklist for our colleagues, junior doctors, to be looking through to consider patients who are going to be higher risk of multi-drug resistant gram-negatives and therefore choose a different regime. So finally, the standard regime for sepsis. So we've got gentamicin or tobramycin plus Fluclox, and then adding vancomycin if there's MRSA risk. If the aminoglycoside is contraindicated, and there's a box for that, then you can replace the gentamicin with ceftriaxone. So you then end up with ceftriaxone plus Fluclox plus or minus vanc. And again, the risk factor box for MRSA. And the one thing I'd like to highlight on here is we do now have a recommendation to include people who currently currently have injecting drug use or injecting drug use in the last 6 months. So that's an important addition to this based on recent evidence that's come out of Australia. So then the standard regime for septic shock, noting that our definition of septic shock is slightly different to elsewhere. So we include either a MAP of less than 65 or a lactate of greater than 2, rather than the combination of both. So the combination of both has certainly been used in research-based studies, but in a clinical setting, the group thought this was more appropriate to have either hypertension or a raised lactate. And here we've got the 4-drug regime, so gentamicin or tobramycin plus Fluclox plus vanc plus ceftriaxone. And this is to get around some of those issues. In the past, we had consider adding ceftriaxone if there are risk factors or clinical suspicion of meningitis, which again, it's a very difficult thing for someone in the emergency setting to be, considering. And so just making it straightforward, getting the ceftriaxone in there, partly for that reason and partly also so that you've got combined ceftriaxone plus aminoglycoside for those that are potentially going to be resistant to one or the other. And then still the recommendation, if toxic shock is possible, add clindamycin. So then the last thing I wanted to quickly talk about was the dosing frequency of Fluclox and cefazolin for patients with sepsis without septic shock. So for patients with septic shock, then we do recommend the higher frequency. So flucloxacillin every 4 hours, or cefazolin every 6 hours. But if for patients with sepsis without septic shock, we've aligned our dosing recommendations with the UCAS dosing recommendations and also aligned with the Staph aureus bacteremia targeted therapy recommendation. And also reflected on a review paper that was published by Amy Legg and colleagues, which makes the recommendations as you see here. So cefazolin, 2 grams 8 hourly for uncomplicated bacteremia, but increasing to 6 hourly with patients with septic shock or complicated bacteremia, so meningitis and endocarditis. And similarly for Fluclox, 6 hourly for standard dosing or 4 hourly, really for patients that are going into the ICU setting. So again, we've tried to make things simple in that, if people are well enough to be going to wards, even though if they're septic, they don't have septic shock. If they've got septic shock, they're going to the ICU, then those are the kind of patients that you'd be thinking about moving into the higher dose regimes. And that's all I've got.
Thanks so much, Ed. Before you run away, though, you already have run away, so I will invite you back. Did anyone have any questions for Ed on those updates to the adult sepsis recommendations? Great. Felicia's just coming with a microphone. If you want to pop your hand up, she'll come and find you. you'll need to readjust that.
That's all right.
No, thanks, Ed. That was great. I was just interested in the fact that they went with gentamicin or tobramycin. I mean, it sort of implies that you think the two things are equivalent, or why did you sort of give both options rather than just nailing one?
That's a really good question, and as you see, we're recommending Fluclox, not Fluclox or Kefazole, and the rationale for that was it's too difficult and there's no good reason for someone to choose Fluclox over Kefazole and the other way around. So we stuck with the one recommendation. We tried to do that with the aminoglycosides, and the aim was to transition to tobramycin, but we recognise there's a lot of places that are not familiar with tobramycin, and in terms of the majority of the gram-negatives, Gent and Tobra are broadly equivalent. We know that Pseudomonas obviously does much worse with Gent than tobramycin, but in a transition phase, we thought it was safest to leave the two options there, also with dosing recommendations being the same for both. But so we understand that tobramycin probably does have some slight benefits over gentamicin, but on the scale of the sort of national context, we thought we needed to leave gentamicin in there. Does that answer your question? Sorry?
You pushed out.
Yeah, we did. Yeah. I mean, it's a very practical decision because if we just said tobramycin everywhere, there's going to be a lot of places that I don't have it, aren't familiar with it, don't have ability to test levels, and so yes, we wussed out.
Martin, microbiologist from New Zealand. I've got to ask this question. This article in Clin Micro newsletter, and this was a publication April 2024, and they argue against the use of aminoglycosides in general, and the only indication they gave was for uncomplicated urinary tract infection. So do we still have to cater for aminoglycoside? Issues we face?
For the first dose in these patients, the expert review was that this is still the way that we want to go. There clearly are a number of issues, not just the correct dose and PK/PD concerns, but concerns around toxicity and all those others. But in balance, and from a stewardship principle, the expert group would still much prefer use of gentamicin, which we have been using for a long time without, and have the experience of using it, against the alternative, which would, across a lot of the UK, they are now using PIP/TAZ as their upfront sepsis, with or without an aminoglycoside, and that wasn't somewhere that we thought we should be going. Yeah.
Would you give for 3 days only, or would you continue according to the clinical scenario?
No, and it's very clear throughout the guidelines. This is first dose, if necessary, a second dose, but then moving on to directed therapy, either based on micro results as they come through, or the empirical guidelines for defined syndrome elsewhere in the guidelines. But yeah, we're really targeting that first dose.
UCAST has that little annoying recommendation about gentamicin shouldn't be used alone for gram-negatives.
Yes.
I just wanted to clarify that when you've added ceftriaxone to the sepsis guideline, that's seen as plugging a hole in sensitivities, and you're hoping you don't get resistance to both, but you're still using gentamicin alone rather than advocating for dual antimicrobials?
Yeah, so the remembering that this is for sepsis of unknown origin. So these are mostly going to be urinary tract pathogens in a complicated urinary tract setting. The intra-abdominal stuff is dealt separately. Yeah. Yeah, we had a lot of discussion about this, but yes, I take your point. And again, once you're moving into directed therapy, once you're putting that comment on, I think it's a very good comment to have, and will drive people to using other agents once you've got your susceptibilities.
Good.
Thanks, Ed.